So in addition to those that we've heard from, also joining the panel is David Brennan from UVA, Rich Price from UVA, and Costas Arventis from Georgia Tech. So, so the first thing that I first wanted to give Dr. Brennan, actually, and Natasha alluded to this, we do have another talk on immunotherapy tomorrow, which is the first clinical trial that's pairing focused ultrasound with an immunotherapy, which is very exciting, and that's going to be in the breast session tomorrow. So I just wanted to give Dr. Brennan the opportunity, I know it's still very early, but to generally state kind of what they did and what they've observed so far.
So that will be presented by Patrick Dillon tomorrow.
Yes.
And this is the first in-human trial combining focused ultrasound with a checkpoint inhibitor to treat breast cancer. The patients are getting, it's a two-arm trial comparing a checkpoint inhibitor given prior to ablative focused ultrasound and then 3 times following, once every 3 weeks, compared to doing the ablation first and then giving 3 doses of the checkpoint inhibitor every 3 weeks following. The trial is ongoing. So far, 5 patients have been treated. 6th one will be treated in December. And right now, our results are awaiting completion of the trial. So.
Okay. So the first thing I thought I would ask all of you to respond, so we have seen a lot of work trying to assess the effects of different modes of focused ultrasound, as I'll call them, whether it's thermal ablation, histotripsy, hyperthermia, and we saw that in the last talk. The foundation has funded a consortium of sites that are investigating these effects in glioblastoma, and you heard from 4 of those groups today. And so I just wanted to see, since many of you have participated in this work, what we can glean so far in those sort of comparative studies. Does anyone want to start?
Well, it certainly remains unclear as to what the best energy is going to be. I think to date, many of us, certainly in the clinical realm, are using the devices that are available for clinical use at hand. But certainly the answer to that question is going to be vital, and hopefully your study is the beginning of that, at least for a mouse model using a tumor model that is easily reproduced, but may or may not represent the real clinical impact.
Yes, and I think the difficulty to this is really the spectrum or the range of parameters that can be modified in terms of the fraction of tumor that will be ablated, of course the modality that we will use for the ablation. We are using, for example, in France, in Lyon, with my team, another type of modality of non-cavitational post-ultrasound, for which we have also different results. So it's really a complex question that needs to be addressed. Yeah.
I think I can speak somewhat to the UVA experience as well with regards to this, because my personal bias, and it's not necessarily a bias because I think the data are starting to support this, is that mechanical fuss is probably going to be preferred for most indications. But with that said, in the trial that David and Patrick are running, it's a situation where we have an FDA-approved protocol which includes thermal ablation. So we have an opportunity right now in our clinical samples to study the impacts of thermal ablation while in parallel continuing to pursue mechanical as an alternative means.
I can just chip in on that. And I think there are definitely the different modes of operation are extremely important. And I think we should at least be able to use MR thermometry or cavitation detection so we're able to quantify these interactions. So I would like to mention that the second important aspect is the tumor microenvironment, and that's extremely critical. And this asks for two questions. The first question is, are there any responses that can preserve across different tumors? And that might suggest that ultrasound can give us some hints in which direction we go. Or we can flip the coin and we can think, are there specific tumor microenvironments that are more sensitive to thermal or mechanical effects? So I think those are quite central questions in deciding which way to go. And the final point that I'd like to make is that combining this with immunotherapeutic agent, combining focused ultrasound with immunotherapeutic agent is extremely important. But we need to start thinking and identify, either through characterization work that has been presented today or through other more hypothesis-driven research, we need to identify what are the immunotherapeutic molecules that are ideal for focused ultrasound, because right now we're trying to incorporate immunotherapeutic agents that have shown robust responses in other ways. This doesn't mean that these immunotherapeutic agents are the best to combine with focused ultrasound. So we need to think in terms of more concentrate on what the FUS is doing to the tumor microenvironment and pair this with respective immunotherapeutic agents.
And the other thing that we need to probably be careful about in answering this question is how much of the tumor that we ablate. So partial thermal ablation may be very different than complete thermal ablation. Certainly the other techniques are probably less likely to result in complete ablation as compared to thermal ablation. So there may be the case that thermal ablative energy used in a certain way may be quite effective as compared to the other techniques.
Yeah. I absolutely agree. Dose fractionation has been shown to be effective in other ways to intervene and modulate the tumor microenvironment, and maybe hyperthermia as a function of time at different time points, or ablation or weak mechanical effects as a function of a week or so, could be like a breakthrough in the field, which might show new antigens in the treated region. But this will take time to evolve. It will not happen with one treatment, I guess.
So obviously, focused ultrasound is unique in that there are all of these different kind of modes or mechanisms of action and how it can perhaps enhance the immune response. But when we look at something like radiotherapy, which is being used more and more in combination with immunotherapy, is there, do you think we can learn from that in terms of maybe paring down or identifying some of the drugs that we might want to target in combination with focused ultrasound? Does that help us at all in that?
Yeah, so I think there are two ways we can learn from maybe radiotherapy. The first one is to capitalize on what is working with radiotherapy. So, for example, in pancreatic cancer, recent studies showing that a combination of anti-PD-1, anti-CTLA-4, anti-CD40 combination with radiotherapy is effective. So why don't we start by using these combinations, for example, with focused ultrasound? Even if it's not exactly the same mechanism, it's remained an ablative therapy, and maybe we can capitalize on this. And also if we want to also to postulate hypothesis, we can also maybe look at what is information from radiotherapies on the mechanism that have been described, and to look for this specifically first, instead of going broad and to narrow the question that we want to resolve.
Okay. Obviously the best way of determining or sort of assessing the immune response is actually in taking tissue samples or direct samples before and after your treatment. But for something like focused ultrasound, which is non-invasive, that's not always an ideal thing to add into a clinical study. So do we know about research going on in areas like imaging biomarkers, or is there work going on in analysis of blood that can help us so that we may eventually not have to take those tissue samples?
So
maybe.
Yeah. So we've been really interested in these questions of imaging and have have recently published some work on following CD8 T cells in combination with various immunotherapies, and there are others. So we took the tact of just looking at CD8 populations as opposed to activation, but there are a number of different opportunities. Similarly, macrophages, there are some clinically relevant methods of following macrophages over time that could definitely give us some information. And I think that also figuring out how to handle tissues and different tissues, different organs, different tumors from different organs is also something that we really need to work with as if we're looking at biopsy and coming up with the best methods to analyze.
Yeah, so just to mention that we started a clinical study in France. The first patient will be included this month to immunomonitoring of patients that are treated by focused ultrasound for the prostate. So it's a case where we cannot have access to biopsy because the biopsy in France are transrectal, so we cannot add biopsies for the purpose of an ancillary study. So we have to monitor the immune response, through the blood samples. So this is what we are going to do to remove blood samples before, 24 hours after, 3 weeks after, and 3 months after the treatment to see if we can to really study the potential differences in an immune response. Now, the danger of this is that it's not because we don't see changes in the peripheral blood, that we don't have changes in the tumor following the treatment. But the control biopsy would be performed 1 year after the treatment, so we don't have any chance to see that on the biopsy. But yeah.
Okay. A final thing I just wanted to see if anyone has a comment on. So the, when we are moving this towards more clinical trials, there's the regulatory hurdle of this is a combination, or, being treated as a combination approach. And so thoughts on, are we better off in initial trials, or will we be limited by needing to pair the focused ultrasound with an already approved therapy, or, because obviously that's important to think about, or will we be able to pair with therapies that are not yet approved? And maybe, Dr. Brennan, you have some insight from your regulatory experience.
Our experience has been it's gone both ways. We're not quite sure how the FDA will feel in terms of, are we looking to do a study on a new drug indication, or is this a device indication? So, and we've had to go both ways with the study applications that we've had to date. I think what we need to do is work with the FDA moving forward, and for all of the new combined treatment indications, probably get guidance from them early on in the development of our study protocols.
I think it's obviously a great advantage too that at the same time that we have this surge in focused ultrasound for immunotherapy, in parallel the armamentarium for immunotherapies is expanding rapidly as well. So even if for these early trials we have to stay with approved drugs, the number of approved drugs and therapies that are available are expanding rapidly. So as we understand the response to focused ultrasound, we can then intersect that response with a number of new tools that are on the way, which is, I think, pretty exciting.
Great. Okay, I think our time is up. So thank you all. We have a break now, sponsored by Histosonics, and we'll be back here to begin at 3:45. Thanks.